Thank you, everyone. And this is the first of, I'm sure, several more virtual webinars to come. So I have been asked to present two abstracts. The first one is the EFS overall survival and safety of adding veliparib plus carboplatin or carboplatin alone to neoadjuvant chemotherapy. This is presented a couple of years back. Incidentally, I presented the same paper 2 years back in the year in review. This is the updated 4-year results done by Loibel et al. At the ESMO 21 Congress. Now, generally, NACT with surgery has become a kind of standard of care for stage 2 and 3 TNBC. The initial phase 3 brightness study looked at addition of carboplatin to paclitaxel with or without veliparib. It showed that there was a better PAT-CR when you added carboplatin to standard chemotherapy. Now, the CalGB Alliance trial found that addition of carboplatin to paclitaxel improved the PAT-CR to 54%. JEPAR-6 showed it was 53%. The brightness again showed it to be around 53 and 58% versus 31%. This was the study design for the brightness. As you can see, all patients would receive adriamycin cyclophosphamide. In the segment 1, you had paclitaxel, carboplatin, and veliparib. Paclitaxel, carboplatin alone, or paclitaxel alone. Now, remember, there is no fourth arm. You do not have a paclitaxel plus veliparib arm. So, essentially, you are trying to see if carboplatin does something good, and then you see if addition of veliparib improves that. So, that's actually how the trial was designed. The way they actually calculated was something more interesting. They looked at paclitaxel, carboplatin, veliparib versus paclitaxel alone. If that met the endpoint, then they would look at the all three versus the combination. That's how the study was designed. Now, the primary analysis showed that when the three drugs were used together, it was superior to paclitaxel alone, but there was no superiority seen to the combination. In other words, addition of carboplatin to paclitaxel improved your outcome versus paclitaxel alone. However, further addition of veliparib did not really show any added advantage. That was the initial presentation. Looking at the trial, interestingly, almost 70 to 75% of patients were T1 and T2. N1 and N2 was only 43%. So, you're looking at a relatively early stage tumors here. You're not having a very high risk TNBC. So, probably what we see is a much more high risk TNBC. The schedule of AC was both dose dense equal as far as the 2-weekly and 3-weekly one. When you looked at a follow-up of 4.5 years and the event-free survival, again, it stayed consistent. In other words, you have a combination of paclitaxel, carboplatin, and veliparib showing benefit over paclitaxel. You have a combination of paclitaxel and carboplatin showing a benefit with a hazard ratio which is almost the same, 0.57 and 0.63. But when you added veliparib to the combination, to the doublet, it did not show any benefit over the doublet. So, your arms, when you see here, the curves are almost matching in the first two, and both are superior to paclitaxel alone. When you looked at the overall survival, here, none of the three arms actually showed any benefit or any difference in terms of statistics. So, your hazard ratio is 0.82, 1.25 and 0.63, but all over the place, none statistically significant. So, your PAT-CR would be better, EFS is better, but no overall survival advantage. Interesting thing which they did look at, considering all the AML and MDS seen with PARP inhibitors, that was not shown to be much different in these groups, but again, the numbers are too small. One other thing that they really looked at was whether this EFS by PAT-CR mattered by basis of your germline BRCA status. So, patients who had germline BRCA mutant versus non-mutant, both versus wild type, in both the cases, patients with PAT-CR had better EFS. So, you could not really select for those patients who would have PAT-CR and who would do better in terms of their EFS. Now, the authors concluded, interestingly, remember this brightness study, addition of veliparib, the end conclusion is that addition of carboplatin to paclitaxel improves your PAT-CR and improves your EFS. Veliparib does not do anything. So, looking at it purely from the viewpoint of a veliparib trial, this is a negative trial. It does, however, strengthen the role for adding carboplatin to paclitaxel as a neoadjuvant, especially in TNBC and for those with germline BRCA. We do know that patients with PAT-CR seem to have better CAPFS. There's a recent meta-analysis by Fioghi et al., where they found the same thing, that across all studies, patients who were having PAT-CR did have improved EFS, though no overall survival benefit. So again, PAT-CR debate is still not completely out, though by and large, we are tending to believe that it improves your EFS. So my takeaways is that addition of carboplatin will improve your PAT-CR. Is PAT-CR the best surrogate? I am still a bit skeptical about it. I will not say it's cut and dried as it is. As always, addition of platinum will improve your EFS. OS, contentious. Can we have a better subset defined? Where would you want platinum? Where you would like to maybe use it in a higher grade of patients? Where in a higher stage of patients? That question is still needed to be answered. But I think we will tend to start using platinums in our patients. One thing which brightness does show is that probably, as of now at least, PARP inhibitors are not a standard for NAC. That's my takeaway. The second paper is characterization of long-term responders following treatment with talazoparib versus physician's choice in EMBRACA trial. Now, talazoparib, like other drugs, has been approved for germline BRCA positive advanced breast cancer cells. Now, EMBRACA trial showed that there was a difference in improvement in PFS versus physician's choice of therapy. Remember, this is PFS. And we do know that the Olympiad failed to show an OS advantage. Predictive biomarkers are not available. Previously, the EMBRACA did analyze and say that TNBC patients have shorter DFS. So this trial attempted to look at those patients who have long and short responses. Now, this is the trial design. Talazoparib versus physician's chemotherapy of choice, capecitabine, eribulin, gemcitabine, vinorelbine, whatever the physician wanted. They identified two subsets. Long-term patients who had an OS of more than 30 months, duration of treatment more than 24 months. So a good subset. Short subset, patients with a DFS less than 3 months. Why 3 months and why 30 months? Why in the one side you're looking at PFS, in the other side you're looking at an OS, I could not understand, but this is what the authors have attempted to do, trying to look at better outcomes. Now, what the problem when you start doing such wide variation is, look at the number of patients who are there. You have 37 patients and 34 patients as long responders, 40 and 32 as short responders. So essentially, out of 430 patients, you're analyzing around 100 patients and seeing what is happening. Now, a greater proportion of long-term responders had HR-positive breast cancer and had received no prior chemotherapy. Again, pretty logical and understandable. Then they looked at the duration of treatment. Again, median duration of treatment for talazoparib was longer as compared to physician chemotherapy of choice. Patients who were long responders with TNBC also had a reasonably long period of treatment with talazoparib. Again, when they looked at HR-positive and at TNBC, the duration of treatment was longer with talazoparib. In short responders, they had very small treatment durations. Overall, what the authors concluded was that patients who had clinical response to talazoparib, a greater proportion of patients with long response had HR-positive cancer and had received no prior chemotherapy. Greater proportion of short responders had TNBC and had received more than or two prior chemotherapy regimens. So essentially, boiling it down, if you are TNBC and have received chemo earlier, you're probably not going to do as well. It is logical and it is something that we kind of know, and this trial has proved it. Patients who are having a longer response are probably those who have HR positive and have not received prior chemotherapy. So additional chemo treatment investigation is needed in larger subsets. Personally, for me, I think in ABC, the role of PARP inhibitors still needs refining. Do we use it in all BRCA positive? Do we use it only for TNB? What about if you have already used platinum? Would you still use a PARP inhibitor? And finally, should we wait until we get a meaningful OS advantage? Or should we go ahead and use any PARP inhibitor in the first or second line? I think these answers still need further refining, which will probably happen in the next year's or year after meeting. So thank you very much.